So I am so happy to be here today. This is such a great conference and is after many, many years of being part of this, I'm really so happy to be here today. And what I'm going to talk about today is kind of continuing on the theme from Marie to talk about age-friendly in practice. So provide some examples of what we've done at the Centers for Health and Aging. We are thankfully recognized as a level 2 age-friendly health system, which is wonderful. And we also have supported primary care practices that are part of our geriatric workforce enhancement program to also be recognized by IHI. So great work. Let's see. I said I would advance my slides, and there we go. So I don't need to go into this too much because of Marie's great talk, but this is, of course, as you know, the framework focusing on the 4 M's. So I wanted to talk for a minute about the Dartmouth Centers for Health and Aging and just provide some context for the work that we've done. So there are 3 centers that sit underneath the Centers for Health and Aging. One is the Dartmouth Hitchcock Aging Resource Center. And the purpose of this is, as I go through this talk and talk about the implementation of some of our programs, I'll refer back to which center has helped to implement that. So the Aging Resource Center is a center that provides direct support, care, education to older adults. Prior to COVID, folks would come here to the center to, again, receive all kinds of education. That's in part where our falls prevention program sits, and I'll talk about that. Since COVID, we actually have stood up most of our programs remote, which has been terrific, and are really pleased to report out that we have had tremendous success connecting older adults to our programs through Zoom. The second center is the Northern New England Geriatric Education Center, and that's where our geriatric workforce enhancement program sits. This center has been funded by HRSA for the past 12 years, and we continue to, and I'm going to talk a little bit about GWEP and the work that we've done there specific to age friendly. And the third center is our Center for Aging Research. And here we provide support and mentoring to clinicians predominantly who are conducting aging research projects across our system. And that's interprofessional and also, I would say, focuses on supporting young clinicians all the way up to senior scientists that we have at the center. So back to the Aging Resource Center for a minute. So what we have been able to do in our system, which is terrific, is we've been able to create an electronic referral to the Aging Resource Center, which we consider our community-based organization. So anyone in the system, whether it be a medical assistant or a nurse or a provider, during a visit can actually just click on very easily and make a referral to the center. And we've provided this kind of drop-down menu that helps people to recognize and to specifically refer people to a program. So here you see it's clicked off for falls prevention. And I'm going to talk in a little bit about what happens, where that goes, and what happens once we receive that. So our falls prevention program, and I have to give credit for our amazing Donna Pigeon, who is actually participating today. And I shouldn't even be opening my mouth about this because this is Donna's program. And anybody who knows Donna knows that to say that she is passionate about falls prevention is kind of an understatement. So this is all Donna. So we have been awarded 3 Administration for Community Living falls prevention grants over the past 5 years. And we started out building capacity for 2 evidence-based programs, Tai Chi Quan, Moving for Better Balance throughout New Hampshire, and also throughout the Northeast, and also for Matter of Balance more locally throughout New Hampshire and some of Vermont. Our latest grant, which was awarded in 2020, we've actually partnered with 2 other geriatric workforce enhancement programs. So just to give the context, there's 49 GWEPs across the country that really focus on improving care of older adults, partnering with primary care and community-based organizations. So this recent grant was really about helping 2 other GWEPs, that's Bay State, which sits in Springfield, and the University of Rhode Island, to help them to build capacity for Tai Chi. And so that is about, again, not only training people to run the Tai Chi programs, but also about developing screening and referral pathways from primary care to these community-based programs. We have a collaboration at the centers with our geriatric ED, which I'm going to talk about, certainly the New Hampshire Falls Prevention Task Force and the network hub that's been developed through that, and our training program. So just to talk for a minute again about Tai Chi, which many of you know that Donna is one of several leaders in the field, in the country, in Tai Chi, and she works closely with Dr. Fuzhang Li, who is the developer of the program. And the evidence around this specific Tai Chi is really overwhelming. It is what we consider to be the strongest evidence in terms of falls prevention, especially for people with Parkinson's disease. And so we have worked to build capacity for these programs through Donna's training. And fortunately, we have been able to provide remote delivery and training for other program leaders to deliver this program remotely, which has really been terrific. A Matter of Balance, many of you know, is an 8 2-hour session program. And I see that Sharon Feeney is on the call today. And Sharon is our Matter of Balance expert at the centers and has really done a lot of work in helping us to build capacity for this program. Matter of Balance focuses on decreasing fear of falling and increasing activity levels in sedentary older adults. And one of the things that we think about when we conduct these screenings is we think of kind of a stepwise approach. So individuals who are extremely frail, and especially as we deliver remote Tai Chi, Tai Chi may not be the best program for them initially, but we think of enrolling people in a Matter of Balance, and then that being the stepping stone for them to then enroll in Tai Chi. So our Dartmouth Falls Prevention Training Program focuses on balance day training. The concept of balance days is something that we developed in our previous ACL grant. And the idea is that not only do you need screening, right? So you need to screen people, but the concept of then not only enrolling, but keeping people in falls prevention programs, right? You can screen till the cows come home, but if you can't get people in the programs, that's really what's preventing people from falling, right? So we created this concept of this balance day where folks would come in from the community, open balance days, come in, not only have their balance screening, but then to have the leader really risk evaluate somebody, and then through motivational interviewing, refer them into the very best program for them. And what we found is that when individuals actually participate in a balanced day, the the likelihood of them not only enrolling, but staying in the program goes up exponentially. We're calling this a balanced day is a bit of a misnomer now, but we do conduct the exact same screenings and motivational interviewing through in-person visits, through appointments, and we're also doing it remotely now. And so part of the training that we do when we go out to implement these programs is we start out helping them think about how not only the screening, but then what happens after the screening in terms of referring people to programs. Our implementation workshop is also something that we've developed through our ACL grant. And one thing that we know about Tai Chi in particular is that it's a bit challenging to keep people enrolled and to keep people completing the program. And so we did a lot of work around using techniques of implementation science to really help leaders think about how they should implement the program and what are some of the tips and tricks and processes that they can use to actually keep people enrolled and engaged in the program. And what we found was that there's been an increase in participation completion rate from 15% to 43% when sites have participated in this implementation workshop. Our 2-day Tai Chi Quan instructor training is 16 hours. And then there is what we call enhanced training, which is actually sometime after a leader is trained to go back to ensure that there's fidelity to the model and to really troubleshoot, coach, and help support. And then we have this 6-month post-training technical support for all the sites. And as I've been talking about our virtual training capacity, which is great. So in the past 3 years, we've trained 168 instructors in the Northeast in 52 delivery sites. I'm going to pivot now and go back and talk a little bit about the work that we're doing through our GWEP. So that's the Geriatric Workforce Enhancement Program that's funded by HRSA, sits within our Northern New England Geriatric Education Center. And when the original GWEP application came out, and many of you will remember that the GECs, this line of funding, really focused on bringing people together in big rooms, big meetings, such as today, and training a lot of people. And HRSA said, you know what, it's really, really hard for us to measure patient outcomes based on this kind of big program training. And maybe what we need to think about is more about transformation. So how can we train primary care practices and then actually monitor patient outcomes from that? So when we first applied for our first GWEP, one of the things that we talked about, and we thought a lot about primary care, right? I'm actually a primary care provider on the geriatric team. And it's been really, really hard, I would say, no matter who you talk to partner with primary care and to train primary care practices. Completely out straight, not a lot of time, a lot of initiatives going on, what we say kind of the flavor of the month. So what we said is maybe what we need to do is to create a model that would use Medicare reimbursable services or Medicare codes, right? So what if we went and helped practices to implement these Medicare codes, right? Which we consider to be a proxy for evidence-based good geriatric care. And we can make the business case for the practice. So yes, the practice has to provide opportunities for their staff to be trained. This is a QI model, but at the end of the day, it's actually going to help their bottom line. So we created a model called GIT-PC, which is Geriatric Interprofessional Team Transformation in Primary Care. And just as a side note, the original GIT was developed at NYU And I worked really closely with Terry Fulmer, and this was after Niche. And Niche was also funded, by the way, from the John A. Hartford Foundation. And the original GIT was funded by the Hartford Foundation. And that was geriatric interdisciplinary team training. And that program focused on training essentially nurses, physicians, and social workers together with didactic and experiential team training. And at the end of that, Terry and I talked a lot about how could we move this from a student-based model to a primary care model that many of us out there have not received formal team training. And what would that look like if we were able to really help primary care teams or already existing teams to improve care? So this is kind of the result of that, this GIT PC. And the goal really was to focus on the quadruple aim, which many of you know, is an IHI concept that says, you know what, every day, what we should all be thinking about is not only improving patient outcomes, but their experience, reducing costs, increasing revenue, and don't forget, we need to have joy in our work, right? And I could go on, I could have given an entire talk on workforce today, but we all know that that the concept of creating teams and joy is really what helps in terms of retention and really helps by keeping people in the workforce. So how does GIT PC work? So we recruit a practice through a standardized process, and this is primary care practices. And we first conduct a practice assessment. So what we look at, and I'm going to show some of that data in a minute, we think about things like readiness to change, right? Team skills. So those are some of the things that we ask participants in the program before we start. And we use those data to hopefully tailor the education that we're going to provide specific to not only team training, but quality improvement, and then some of the specific content training around those codes. So once that's done, each team member in these practices participates by completing some asynchronous modules. And what we found, and actually this was before COVID that we started to do some of this virtual training, what we found is, you know what, for every code, there's kind of some boring content, right? You need to know all the kind of the rules and the details. So you don't need to have some talking head at a conference telling you that. You could sign on and do these asynchronous modules. And that really helped primary care practices as well, that folks could do this when they had a few minutes. And then after that, once they do the asynchronous modules, they actually participate in live virtual training. And we call that a boot camp. And at the boot camp, we pick up on the two themes of teams and quality improvement. And instead of kind of repeating what was in the modules, it's really all experiential and exercises to really get the teams working together around this teaminess, shall we say. And then they have the education, the live education, go back to their practices and begin to implement the code. And then we coach them in a collaborative, right? So a learning collaborative that happens once a month. We bring practices together, and it focuses on them submitting their data specific to some process measures as well. So for example, the annual wellness visit, it's absolutely key that you communicate clearly with a patient what the annual wellness visit is, right? You don't want a patient coming into the office thinking they're going to get their annual physical, because that's not what it is. So thinking about these process measures, and then actually also collecting data about how many annual wellness visits that they're doing. So these are the 4 codes that we have identified as codes that, if they're implemented in a practice, that actually is evidence-based geriatric care. And many of you are familiar, I'm sure, with the annual wellness visit. And I would say the annual wellness visit and the chronic care management codes are probably two of the more challenging codes for practices to implement. The transitional care management codes, a lot of people are doing, a lot of practices are doing. And the interesting thing about the advanced care planning codes is that they are so simple to build for these codes, and very, very few practices are doing it. So we provide several models and coaching around how they build for this time-based code. When we think of the annual wellness visit, back to the 4Ms, I call the annual wellness visit the gateway to the 4Ms. So the annual wellness visit includes screenings. That's what it is. It's a preventive visit that includes screenings around the 4Ms, right? So that visit in and of itself provides a practice with a great opportunity to implement the 4Ms. And part of the work that we've done in coaching practices around age friendly, we say to them, this is what you need to do to be recognized, right? So what you have to do, as Marie pointed out, is you have to identify, right, a practice, a specific process that you're using to deliver 4M care. You can't just say, I'm going to screen for depression or I'm going to screen for falls. You have to think about this in the context of these 4Ms together. So the annual wellness visit is absolutely perfect. So you create, so the practices that we've worked with, they apply for accreditation, for recognition as level 1. And then when we start working in the learning collaborative, and for 3 months, they can then present their data to IHI to be recognized as level 2. And right now, the practices that we're working with, 3 out of the 5 practices have been recognized now as level 2. So that's terrific. This is a map showing our regional implementation of the GIT PC. And again, this happened, the maroon colors were the cohort 1, green is cohort 2. This is where we've implemented this nationally, working with, again, some of our GWEPs. And I wanted to share some of our recent baseline data collected during the COVID implementation of this model. And this shows the results of something called the Boviak scale. And this scale measures readiness to change. And I'll just take a minute for you to look at this. It's really critical that when we engage with a practice, that we have a good understanding of their readiness to change and flexibility. This slide shows some baseline data for the Heinemann-Schmidt attitudes toward healthcare team scale. Again, this looks pretty positive starting out with just a few disagreements that are noted. This shows the baseline for self-perceived team skills. And what we've thought about is based on the results from this scale. Do we need to do some remedial teamwork, right? Should we say, you know what, before we even get into the implementation of this code, we think that maybe we need to drill down and dig a little deeper and take a look. And this is a continuation of the team skills scale. It's very interesting. One of our practices that we implemented in cohort 2, there were some red flags when we got this data back. It was, we went to implement with the live virtual training, and it was a total disaster. It was terrible. And in fact, that was the only practice that we actually pumped the brakes and we said, we can't do this here. That there was so much dysfunction on this team and there was bullying, and it was just awful. And we recognized that, like, from the initial training. And when we went back to the sponsor and we said, wow, there's some real problems here. And we're not going to be able to work with this team. So we've implemented this in 50 primary care practices, and that was the one practice. And it's interesting because we saw it, right? We this was early on, but we all got together and we looked at that and we're like, there may be a problem here. And well, it turned out that's came to fruition. Um, I want to talk for a minute about our geriatric emergency department. 3 years ago, we were approached by the West Health Foundation to think about becoming accredited as a geriatric emergency department. And that accreditation has been developed by the American College of Emergency Room Physicians, Emergency Room Nurses Association, the American Geriatric Society. And so West Health said to us, we haven't done a lot of this work in rural areas. So what if you were to become a level 1 accredited geriatric emergency department in Lebanon? And then what if you worked with 4 rural hospitals to help them to implement the concepts of a geriatric emergency department? And we're going to expect you to become level 1, but we don't expect them to get to that level. We would love if they could be accredited as level 2. So it is literally a hub and spoke model. And I am very pleased to report that we became level 1 accredited about 2 months ago, and have moved this forward. We are now working with 2 hub sites, which are small rural hospitals. This is the concept of the geriatric emergency department, and it's often referred to as kind of the front porch. And the concept being that when an older adult arrives in an emergency department, one of the first things that should be done is to determine what matters. What are the goals of care of this patient, right? Now, we're a level 1 trauma center. So you know what happens when somebody arrives in the emergency department, right? Everything that we do is protocolized, right? This is what happens. Somebody hit their head, get them into the CAT scan, right? That's what happens. And we save lives, right? That's what we do. It's a trauma center. But what about the person with, moderate to end stage dementia, right? Who fell, hit their head, maybe they were in the nursing home, maybe they have a laceration that's bleeding that can't be stopped, right? So they get sent to the emergency department. Should they be put into the CAT scan? Absolutely not, right? Unless somebody is considering brain surgery for a subdural hematoma, there would be no reason to have a CAT scan, right? And I don't need to get into here what happens when you have somebody who is frail with cognitive impairment who's in the emergency department. So the concept is to create a kind of a kinder, gentler experience for older adults. And we think about the implementation of this through the 4 M's. And so immediately, first off, what matters most to that patient and identifying that. And a lot of this work is done through a trained geriatric team that is in the ED. And I think that what we find, and when we look at the evidence, is that, well, a lot of this stuff, certainly as a geriatric nurse, is what I would call a no-brainer, right? You know that people fall in the emergency department. You need to have lights on. You need to have food for them, right? Is that this doesn't happen in most emergency departments, which is so, so sad. So you have to implement this in a very systematic way to be able to provide, again, this age-friendly care in the emergency department. And the big concept around these rural hospitals is don't send these people to Dartmouth, right? Keep them in their community. And even if they are at Dartmouth, the patients who come to Lebanon, get them home, right? So it's a really close collaboration with community-based organizations to get people home to be able to, again, achieve the very best care, focusing on what matters most, because most patients don't want to be in an emergency department, nor do they want to be in the hospital, but maybe because of a caregiver situation, or maybe for the level of care that they need, there was no choice. So how do we connect and bring people back into the community? I want to talk for a few minutes about an initiative that I'm leading at Dartmouth. Back in the fall, Sue Reeves, who's our vice president at the hospital, approached me and said, there's a number of things that are happening across the system that are really making a difference in the lives of older adults. And what we see here is a lot of silos. That's not shocking to most people when you think about a system. And what would it look like if we were to create this center of excellence in geriatrics? How could we create a system that feels different? It feels different when an older adult walks through the door in any of our facilities. And that goes from the receptionist, who understands that somebody may not be hearing them, that somebody might have visual impairment, that somebody's about to fall down, right? So how do you get every single person throughout a system? We have about 11,000 employees now, to recognize that it's different. It's different for an older adult to receive their care. So I created this model that really focuses on advancing vital aging and the highest quality of care for older adults. That's the mission, right? And as many centers, this has these 4 pillars of direct care, education, research, and policy, not dissimilar to many centers. And when you look at these 4 arrows, what you see is the quadruple aim, right? Quality, experience, cost, and workforce, with quality focusing on 4M care. So this entire center is being structured around age-friendly health system. Let's go back for a minute. And so between the work that we've done at the centers, the geriatric emergency department, we're actually implementing the geriatric surgical verification program, which focuses on identifying people in part who are coming in for elective surgery, who may be at risk for delirium, right? That's one condition that we really, really worry about, right? And we know at Dartmouth that our average length of stay is about 5 days for people 65 and over. Well, it's 10 days if you have any type of delirium in the hospital. So it doubles the length of stay. And again, that's not surprising to many people at this meeting today. And we have worked closely with the wonderful Sharon Inouye in the University of Massachusetts, who's developed the HELP model, which is the Hospital Elder Life Program, to identify people who potentially are at high risk for delirium. And then there is this set of interventions around preventing delirium. So the idea is to think about how all of these initiatives across our entire system can come together, and we can really think about this age-friendly health system. One of our new providers who just joined us approached me last week with just this great idea that's so simple, and it's just fabulous. He said, I want to conduct focus groups with security, housekeeping, kitchen staff, like all these support ancillary departments, and talk to them about what they see in the system, right? What it's like when they are performing whatever it is, their tasks that they're performing, and older adults, and how that impacts on the lives of older adults. And then from there, springboard that into some training, some very basic training about sensory deprivation, cognitive impairment, balance issues, for older adults, which I think is just such a wonderful idea. But again, an example of how the Center of Excellence will really work to transform care. I think one of the things that we find, as a lot of you do, I'm sure, is that just sometimes, just, there are so many roadblocks, so many challenges. Somebody has a great idea. They need to hire a community health worker. Well, it takes 9 months to do that, right? From the time that you're justifying the position, where are you getting the funding? It's got to go to this committee, that committee. So the idea of this center is kind of, how do we grease the wheels? How do we have a seat at the executive table to be able to get these things done in a timely way? The center will also have a core staff. So we will have nurses, physicians, physical therapists, geriatric pharmacists that we can, quote unquote, lend out to pilot some of these programs that then can translate into additional funding for some of these programs, and also to think about philanthropy. So this is something that is near and dear to my heart, and I'm looking at the clock, realizing I don't have much more time, but we think a lot about what matters most, especially for people with serious illness. We define serious illness at Dartmouth as having a prognosis of less than 2 years to live. And part of that is thinking about what is known as the surprise question. So there are many different ways to identify people who have a poor prognosis of less than 2 years. But in the literature, what you see is that one of the most effective ways to do that is to ask people, ask providers, who out of their panel would they not be surprised if they passed within 2 years? Many of you won't be surprised that actually nurses get it better than doctors. And then identifying, so first identifying those people, and then how do we work with them to document their goals of care and their values. So many older adults certainly want to put limits on healthcare, but they really don't know how, right? And so what we see is this overutilization of resources. How many times as a nurse, I cared for somebody who was in a critical care unit, really recognizing that just knowing that if that patient had been asked, right, 6 months before, that they wanted to be back in the ICU again, that they would have said, no. Yeah, I'll go to the hospital. You want to give me some intravenous Lasix? I have congestive heart failure. Okay, but I don't want to be put on a ventilator again. And if it comes to that, just really provide comfort measures and maybe get me home on hospice. So part of that is really what's prompted this work. And for serious illness conversation, we really focus on the completion of the PULSE document, which is in New Hampshire. Many states have a MOLST, a COLST, a PULST. In New Hampshire, we have PULST, and that is provider orders for life-sustaining treatment. So this goes one step beyond advanced care planning. Advanced care planning is really working with an individual to find out what their values are and what matters most. A PULST is an order, right? So you can have it documented on a chart what a patient's values are, and you hope that somebody's looking at that, but it's not an order, right? And unless you have a documented order that somebody does not want to be on a ventilator, then it's very, very difficult in a system to be able to honor somebody's wishes. So generally speaking, on a PULST form, what we're identifying is whether somebody wants full care, limited care, or comfort care. And as most of you know, most people fall into some of those middle categories. This is the PULST form. Right now, we are working on 2 initiatives to scale this model to have goals of care conversations. And we really want to increase the number of patients with POLST forms documented in our medical record. And it's not that an advanced care plan for a 50-year-old is not important, but what you really want to know is somebody who has less than 2 years to live, what is it that they want? And so one of the programs that we have is this 2-step process whereby registered nurses begin the conversations in an office. And this goes back to the advanced care planning codes. So those advanced care planning codes are actually time-based codes, but that time doesn't need to be spent by a physician. So you can have a patient come in, spend time with a nurse, half an hour with a nurse who is talking about values, talking about what their goals of care are. Then the patient is handed off to the provider for a regularly scheduled visit, and then the provider completes the POLST. The provider can then take the time that was spent by the nurse and bill for that time. So it's kind of a win-win. Again, looking at the time, I want to give credit to Ariadne Labs, the serious illness conversation training, which is part of our training. And we do that training here at Dartmouth. And then we have very specific geriatric POLST training. So the serious illness conversation training is really training people in communication and how to have those conversations about values, regardless of whether or not, I mean, the communication training is really helping people to have those difficult conversations with patients. Then we do POLST training, we do role playing, which is extremely important, and elbow to elbow coaching around the model. Obviously, COVID has brought a lot of this work to the forefront, and it was even more important as we went at the beginning of the pandemic. And so what we did was we trained medical students to work with surrogates of dementia patients in the nursing home to have these conversations. And again, back to what matters most. And the feedback that we got from the medical students was phenomenal, that they obviously had not been trained to have these conversations and how valuable this was for them. Whew, I think I finished on time. Did I, Ann?
We started 1 minute late, so you were perfect. And I think we just had a couple of questions. This is break time, so I think it's worth giving you the time to answer there was one question about the HELP model. I heard hospital elder or something, but Amy from Cheshire was asking what the link was for that.
Yep. So it's the Hospital Elder Life Program, and that program is being implemented by the American Geriatric Society. So you can just go on to the American Geriatric Society website, which is americangeriatrics.org. And if you type in HELP, it'll talk about how you can implement this model in collaboration with AGS.
Okay. And I put the link to POLST, the order forms for New Hampshire. That's the Foundation for Healthy Communities.
Thanks.
One thing, could you just mention, because I know there's a specific advanced directive that comes out of Dartmouth for dementia patients that some of us are just getting wind of. And I don't know if you've worked with that, but that's something I would love to in the future learn more about. Have you been connected with that, Ellen?
Sure. So that was developed by one of our geriatric psychiatrists, Dr. Bob Santulli, which many of you may know. Dr. Santulli's work has really focused on Alzheimer's dementia caregivers and patients at Dartmouth. And so many of you saw, I'm sure, the work that was done out of the University of Washington. It was first published in the New York Times. So you could Google New York Times, University of Washington Dementia Directive, that's what it's called. And so Dr. Santulli took that concept of asking people specifically, right? Would your goals of care change? Would your what matters to you change if you have Alzheimer's, if you have dementia, right? So I think what we all know is it does, right? So many people say, if I develop dementia, no way do I want to be in an intensive care unit, and I want comfort measures. So it's an opportunity to have those conversations with patients, and that is a separate document that is an addendum to a advanced directive. Thanks, Laura just posted it in the chat. So, and Laura Gerard has worked tirelessly at Dartmouth on this program and is one of our lead advanced care planning facilitators and educators.
Okay.
Ellen,
Thanks, Ellen.
there was one more question earlier. Could you please just repeat the name of the readiness to change scale that you were showing earlier?
It's called the BOBIAC, BOBIAK.
Thank you.
And I think it's on the slides. I assume you're going to send the slides to people. Yeah.
Okay. Thanks, Ellen. I love